Welcome back to Splits and Whiskey. My name's Sam Patrick. If you don't remember, if you really want to learn everything about me, go back to episode 9 and listen to the episode where Liz interviewed me initially, and you can have my full backstory. But this show is no longer about me, but since it is a Splints and Whiskey show, we got our splint. We're going to get a little bit of horse soldiers here. Again, no one's sponsoring us yet, but if anybody's interested in sponsoring, please feel free to contribute to the cause of helping prevent the walker dip. So before we start off the show, I was talking to Randy here about how can we take this podcast and continue to evolve it. And Randy is a bit of a legend in the space that we're going to talk about today, and she is on the forefront of kind of helping prevent the walker dip on one of the most valuable assets what we have in the field, and that's blood. So without further ado, Randy, I'm going to turn it over to you so you can introduce yourself and we'll chat for a little bit.
Thanks. I have my contribution, and it is an appropriate off-duty save yourself. So cheers to the theme of the show. So I'm Randy Schaefer. I would say I am not smarter than anybody else out there doing this. I'm just working really hard, and I have learned a lot. I saw firsthand the walker dip. And I don't think if I had come out of the AMED Center in school, seeded the capabilities development role prior to my last deployment, I probably would not have recognized what it was. But I saw care from when I first deployed in '05 and '06, and we were implementing the type-specific whole blood walking blood banks in the hospital. Second deployment, op-tempo wasn't as busy in 9-10, but that was really when we started looking at some alternatives out there for managing pre-hospital hemorrhage. To my deployment in 16-17, where I had the opportunity, I was the CJTF ClinOps. So I worked for the 3-star for 18th Airborne Corps. And we were basically establishing the theater at that time. Everybody had left Iraq. Literally, everything that we had built was stripped down to the studs. All the copper wiring was gone, everything. And anybody that was there during both times were like, what the hell? And some of the first calls we were getting were, hey, Colonel Schaefer, how do we set up a walking blood bank? And I was like, fake, what have we been doing the last 20 years? It was so ingrained in our DNA, '05, '06, when the op tempo was high in Iraq, and then, as things picked up in Afghanistan a little bit later, that I was a little befuddled that I was getting these calls. And so I was like, holy crap, I think this is the walker dip thing. And then that expanded to, the operations order for OIR didn't have the vampire program written into it. So I actually had the pleasure, and sadly it was already once the theater was building, of writing that frago, of figuring out and getting calls, from the medevac units, like, can we carry blood?
Yeah, and so for a little backstory for people, since we're talking walker dip, and we're expanding our listener base outside military medicine, even people inside military med might not understand. So the walker dip's the concept of basically us relearning lessons we already knew from the past. We just closed the book and didn't open them. And to be fair, I think whole blood in the field is probably the biggest example of this, because it was used first, early use late in the 1800s, then consistently through World War I, World War II consistent, same thing with Korea, Vietnam, and then obviously HIV broke out, which caused a significant concern. But it's like, the story is like OIR, for those who don't, Operation Inherent Resolve, is when we reopened Iraq. So we had already, I was in Iraq in '09, carrying blood products back then, and here we are reopening a theater, and like, oh, wait a minute, we don't know what we're doing, and it's happening all over the place. And like, I think some of the stuff you're working on, and in case you guys didn't quite understand, Randy Schaefer here was a pretty badass Army nurse, and she won't say it herself, but like, yeah, when Colonel Schaefer, let's not forget that, and like was in the thick of it at all levels of Army medicine. So we're not going to let her sell her. But right now, like, you're working heavily in the civil space to bring whole blood to communities now, which, to be fair, I don't think, correct me if I'm wrong, I don't think we ever saw whole blood in the field prior to the lessons learned from GWOT, the Global War on Terrorism. Is that correct?
Correct. On the ground side,
Yeah.
we had no blood products. So it wasn't until 2016 that the first ground agency started carrying pack cells and plasma. And
Yep.
that was just outside of Houston. That effort led by, again, military, us
Mhm.
old broken folks now
Yep.
going, hey, man, we learned a lot. Even looking back, I'm like, oh, maybe we should have done that better. But we can't let these lessons be forgotten. And when you really look at the data on the civilian side, I mean, we've got thousands of people who are dying of pre-hospital of hemorrhage. And that's all comers, by the way, which we
Yep.
can talk
Yep.
about a little bit later, is it's just not trauma. OB, GI bleeds.
Yep.
Like I am a GI bleed waiting to happen. I don't know
Yes.
how my stomach lining has held
Cheers.
to coming. There we go. So it's all these patient groups that are benefiting from
Yeah.
pre-hospital blood that started, in that military environment.
And you're hitting the nail on the head. Like, I love the point you brought up. Like, bleeding is bleeding. It doesn't matter if it's traumatic. It doesn't matter. Like, if you're losing your blood and we're not replacing it with anything but blood, it's like I use this analogy when I'm teaching lay rescuers. Like, if my car starts leaking oil, I'm pretty sure I've used this in another episode, but we'll use it again. If my car starts leaking oil, I'm not running to put antifreeze in it while it's still running.
Right.
And yeah, like, and that's the best way I can describe it to non-medical people. It's like, all right, your low oil pressure light comes on. You're going into shock. And look, we're doing some training. You go into shock. What do? You pull the rig over, you turn the motor off, you check your oil level. If you need to add oil, you put it in. What's the best thing we can do for the civilian population of its trauma? You stop the blood from coming out, and then you put
Mhm.
it back in. And if you can't stop it, like GI or OB, you can, there's techniques, but it's like same exact concept. So that's why I like to try to simplify that down to the lowest level, because then more people can have buy-in. Because right now, from your perspective, I'm going to ask this question. We try to avoid like throwing people under buses, but from your perspective, what is the biggest hurdle to the adoption of whole blood or blood products in the ground EMS system in America?
So I would say there's two hurdles we have to get over. One is scope of practice. We have there's still, I'm going to say 6 states out there that do not allow medics to initiate a blood transfusion. So they can monitor it. And remember, that was born out of these interfacility
Yep.
transports. I start the blood in the ER. The paramedic can monitor it while they're going. But if that blood ran out during the transport, they weren't allowed to hang a new bag. So depending on how the scope of practice works in each state, that's the number one barrier.
Mhm.
And that's where I'm trying to be an advocate that medics are making the right call.
Yes.
They know when a patient is dying in front of them in hemorrhagic shock.
Right.
Some of that is maybe a little parochialism left over
Yeah.
from the nursing and physician community,
Hmm.
um, that they're the only ones that can, safely transfuse blood. And I would say I've worked with a lot of really smart military medics. They are absolutely making the right call.
Yep.
Uh, so we're working through that barrier. We've had some states recently change their practice so that through either, the legislative process or
Nice.
applying for a waiver or a variance. California is a great example
Yeah.
of that, where their scope of practice is delegated down to the county level.
We're the same way in Washington. It's great. The West Coast, we're just here to make it really complicated for you.
So we had to do a little bit of work, and along with that is that we'll just get them to the hospital.
Yeah.
We had a lot of pushback from some of the trauma surgeons, some because we've got some amazing trauma surgeons
Right.
out there on the pro side. Just that get them to us, not understanding what we understand, that it's a continuum of
Yeah.
care. It's not what you do in the pre-hospital is your own thing. What we do in the hospital is our thing. What evac does.
Right. Yep.
It's from when the time the bleeding starts. Definitely the message that we're trying to hammer home. It's not dispatch call. It's not
Yep.
transport time. So
That's
that kind of lumps into the first barrier.
yeah, absolutely.
And then I would say the second barrier is that EMS how EMS is funded is
Mhm.
mind-boggling. And I have had to learn a lot coming out of the military.
Mhm.
When I was setting up the program in South Texas, I had one of my helicopter bases shut down overnight. They had a no notice shutdown, and they're like, "Hey, we're shut." Like, that blew my mind. I'm like, "You
Yeah.
could do that? How
Yeah.
how can you legally?" They're like, "Where do we turn the blood into?" Come out of the military. I was floored by
Well,
that.
it's a great thing to bring up because like that's the thing, like, and that's why like expanding the scope of this podcast is like Walker Dip, sure it's a military idea, but like you think like yeah, we start exploring the civil space. When I was working for the counter drug program out here teaching cops, like there's 16,000 different law enforcement agencies with chiefs that can determine policy. It's like, so that's just LE and adding fire adding EMS. It's like, and that's the thing that the US population doesn't quite realize. Like I call it civil defense, not the first response enterprise, because it is what it is. But like it is so not disorganized. It's just there's no unified command unless something really big happens.
And even then, I would say it is more luck than practice.
Yeah, well,
I don't
we
I'd
had
say
we had Mike Marsh on the show not too long ago, and he was the EMS chief, like the officer that was responsible for like the triage of the Asiana crash in SFO back in I think 2016 or 18, that window. And like just hearing some of his stories, like yeah, it's so dependent. Hey, hello, everybody out there! Just so you're aware, your first responder space is so dependent on who's on shift that time. Just lesson learned. Learning the hurdles, and that for since you're working, and that's a question for you on that level. It's like since you're kind of working that upper legislative space, are you doing legislative engagements at all?
yes, and that's part of the coalition, the
Mhm.
Pre-Hospital Blood Transfusion Initiative Coalition, is that we're looking at these barriers. What are the barriers and how do we overcome them? Because
Okay.
they're all achievable. It just takes a unified effort. And part of that is engaging legislators, whether it's at the local, the state, or the federal level. Because it ties back to money. Because if
Right.
I can't get some of these EMS agencies compensated, it's an expensive intervention. It's not the most expensive, but when EMS across the board is having some funding challenges, depending on what service model you have, there's some that are hesitant to take this on since it's a product that you can't put on your shelf for years,
Right.
right? It's a liquid product, cold chain requirements. So they're a little less, I guess I wouldn't say enthusiastic. They're enthusiastic. They're just more cautious about the business decision behind it.
And that's something that we take like from the military side. Even the military side, we have like some business decision making. I know, like what was Fort Hunter Liggett the first agency in California to carry blood?
Yes,
Yeah.
yes.
A federal agency like breaking down the barriers and hey,
Mhm.
I'll throw barbs at California DOH, figure it out. I
And
can
we're
do
getting
that.
there. We've
Yeah,
got one live in California now.
that's phenomenal. Because like I think you hit the nail on the head. Rolling back to something you said, like so, I want to also hemorrhagic shock. I want to touch on that since one thing we're really good at the medical community is we use terms that no one else understands. Like so, I've even had cops, like people who are in first response space, like even EMT basically, what's hemorrhage? I'm like, all right, bleeding, mate, just
Yep.
bleeding. So for those who don't understand the shock, there's multiple different kinds of shock, but what we're talking about here is hemorrhagic shock, and in my humble opinion, probably the easiest to correct because hey, I'm leaking stuff, put it back in. Um, all right, all the resuscitationists out there, don't get mad at me for the hypergeneralization. I got it. You can save it for the comments. But like, what we're talking about is you're leaking red blood, put it back in.
Mhm.
Obviously, we want to stop the bleeding. That is the definitive care. That's what surgery does, is it stops the bleeding definitively in the field. If I can, I'm going to stop it. But if I can't stop it, I'm going to start dumping it back in as fast as possible, just like a crew chief dumping hydraulic fluid in a helicopter and frantically pumping and keeping the helicopter in the air. So
Right.
like same exact idea. So just wanted to touch on that now, since we are doing a training discussion slightly. We're going on, I like to do stream of consciousness. It's fun. How much are you focused on the training space of administering blood versus the trying to get it into the systems?
So equally, I recognized when I was asked to help develop the program here in South Texas that you're dealing with a population that's never been exposed to blood transfusions
Mm-hmm.
before. Helicopter EMS, it was a very easy transition because a lot of them were already carrying products or they had a nurse on board that has an ER or ICU background. But ground, I had to treat a little bit differently, not because they're not smarter, they just have not had an exposure to this topic. So spend a little more time, going over the fundamentals of blood transfusion, helping them look at equipment
Yeah.
that works, because there are a lot of choices out there.
Mm-hmm.
And some aren't great for, different types of missions. That's part of the equipment selection when I
Right.
talk with an agency is, what's your mission set? If you are working out of a pack, maybe you want to try this setup. If
Right.
you're mounting it shore power in the back of the supervisor vehicle,
Yep.
maybe you want to try this. They are doing a tissue transplant. Oops, sorry, I snuck over something there. In the setting. So, in terms of training, how I view it as I want them to be empowered and confident to use it,
Mm-hmm.
but I also need them to have a healthy respect that they're potentially doing a tissue transplant in the field and they
Yes.
need to have a respect for the documentation, the quality
Yes.
assurance, and the clinical follow up that are
Yes.
required. So, my training kind of tries to manage all of that.
And I think that's important because that's one thing we do too on the military side. It's like I'm not gonna say we're sloppy on it, but like I would say there's military training in general. I just finished up doing medic tables, recertifying medics, and it's like it's not so much sloppy. I think it's more of just like we don't truly give these guys an understanding of the nuances. Do you see that the civil systems are having a little bit better grasp of the nuances of like the tissue transplant essentially, or is it kind of still being glossed over, or I guess what are you seeing?
So I would say they're doing it better because they're touching patients every day, right?
Yes.
We do a terrible job of that in the military.
Mm-hmm.
So I work with a couple of EMS agencies, and we've developed this thing called the Spark Academy, and it's selective pre-hospital advanced resuscitative care, looking at a care bundle of blood transfusions, TXA, calcium, stop the bleed. And I have taken some of the medics out on the civilian side at New Orleans and Florida, and we actually went up to Alaska earlier this year
Nice.
and taught the medevac National Guard, some of the civilians. And, I very blatantly told the military folks in the room, these guys are better and smarter at this than we are right now. So that's why they're here teaching you, because
Absolutely.
they're dealing with gunshot wounds every day on the streets of New Orleans. Charlie out of Florida, they're dealing with, MVCs, all kinds. So this is where that walker dip, my passion for trying to offset it, is that we've lost experience on the military side.
Yep.
And I saw that just in my trip up to Alaska, and I'm so grateful that they reached out for help. Is that you had a kid who was just out of AIT. He'd been out of AIT 3 months.
Mm-hmm.
He was so motivated, but passed out cold when we stuck him to do a walking blood bank. So it's,
Yeah.
because he never really had been exposed to that. And then some of the senior medics, who had the right shoulder patches, it had been years since they'd really done any patient care. And I would offer the National Guard is probably going to be better at it. And
Well,
I saw this in
yeah.
OIR because they're doing every day in their civilian life versus
And,
some of our active duty units.
and that was the precedence for like the Army medevac program to give flight paramedic is because you saw all your guard flight medics who were doing this stuff, either street medics or their flight medics in the civil space, and then getting patient contacts, and like that's that's a whole different discussion for another day because like I'm with you. I'm realizing some of these medics that are coming through tables, we're having them run on simulations. Like that's going back to the simulation thing. They're sticking IV arms, they're running on mannequins that have some biofeedback, but like they're literally not getting patient contacts. Period. Period. They're not touching people. They're not touching people. Just there's so many layers of that, which is crazy to me. Are you?
But we
No,
haven't learned.
it's not.
We have not learned. That's what kills me. Why I
Mm-hmm.
bang my head against the wall. And now that I'm out of the military, this is my attempt to try to do more.
Right.
to influence that.
So that's why we do podcasts, because we can say whatever we want to wake up the. That's honestly, like, when I started messing around with this, I'm like, I don't really want to put my face and voice out there because it's annoying to me. But hey, like, this is how we facilitate change. We're not the old curmudgeons in the room, but like, I'm seeing, like, you just don't know what you don't know. You got people
Mhm.
who've never dealt with a sick patient. I don't have a solution for it. I don't think anybody does, besides, like, we can't just stay at war with high casualty rates. That's, to be honest, when it comes to the reps, that's where you get them. So working up in Alaska, a question about the model. So, like, since this is half an education podcast as well, for the systems you're seeing, I know, like, up here in King County, Washington, the blood is carried on the medical service officer rig. So, in the way our system works in King County is, I think there's like 7 or 8 MSOs on shift throughout the county. If a ALS rig gets toned out and it's a call that sounds like they need blood, MSO starts heading that way. The aid cart or the medic 1 units can start. They can do everything but spike and hang blood because they don't have it. How many? I guess through your experience, how many? Like, what is the broad majority of systems using for their whole blood or their blood in the field model?
I would say the supervisor model works the best. I'm so sorry. I thought I had that on silent.
It's all good. You're
It's
a
all
busy
good.
person. You should get all the notifications.
Nah, it's all good. Like I said, I'm just trying to figure this out. And I somewhat facetiously, but in a truth, this is a little bit of PTSD therapy for me being able to do this,
Oh,
right?
100%. Absolutely. No, like, trust me, there's so much. Yes.
So, yes, so that is the bonus to what I'm doing. So I would say the a supervisor model is the predominant one that you use, and I say a supervisor. So you've got King County, you've got San Antonio Fire, who have medical supervisors.
Yeah.
We have some areas that don't have medical supervisors that are actually the battalion chief for the fire department carries the blood. In some of the smaller rural systems, they may put it on the ambulance, one end of the county to the
Yeah.
other. And a lot of that is just driven by trying to be good stewards of the resource.
Yeah.
And, when we were rolling it out here in San Antonio, we had to make some decisions from a regional perspective, which if anybody's heard me talk about blood response, it needs to be done with your partners, local and
Yes.
regional. And San Antonio runs 55 ambulances in
Oh,
a
wow.
shift. Can I put blood on 55 ambulances? Sure. If anybody's got a paycheck, checkbook, sure, we can do that. But we didn't feel that was going to be a good steward of the blood and of the taxpayers. So opted with the supervisor model where the city's divided up into 7 sectors now.
Yeah.
And that allows to cover, the operational reach.
Yeah.
Because you can cover a lot more ground that way.
And I think, thinking about the model, like, obviously, if we could ever get artificial blood products that are low cost and shelf stable, yes, every rig. That's where, like, the freeze dried plasma that's getting slowly drugged through the FDA approval process I personally think would be a game changer for a lot of these rural agencies. Then you can just have it. Yeah, it's not perfect, but gets you at least clotting factors started. For your models you're seeing, like, I'm under the impression, so correct me if I'm wrong, but I'm under the impression that for San Antonio, the blood goes to the field for 2 weeks, then comes back to the blood bank, they spin it down and push it to the hospitals.
No, so that varies depending on where you're at in the country. And this is part of the challenge is access to a blood supplier. So the South Texas model is they are using low titer positive whole blood with CPDA1 as the additive. So that means the blood bag can keep the blood for up to 35 days. So the blood will go from the blood center out to EMS, either air or ground, for 14 days. If it's not used, it's rotated back to South Texas Blood and Tissue Center, where they undergo a quick quality inspection, which, by the way, I thought was this like really rigorous process, and they're doing all kinds of testing and analytics.
They're like, no, looks like blood. Cool.
That's exactly. They look and make sure there's no clots. They take their temperature gun, shoot it, and make sure it's within range, and that's it. And then they turn around and sell it as a short date item to hospitals. This is a process they do every single day with hospitals. If blood's not going to be used, they'll take it and sell it to another facility. So the hospital does assume the risk that when it expires, they're going to be on the hook for it. But that's okay because the patients are arriving with improved shock indexes,
Yep. Mm-hmm.
a little less sick, needing less crystalloid resuscitation. That's the optimal model.
Right.
Now, we do have variations because there are something, and I have to double check myself on this, 100 independent blood centers in this country. So it's a business. So they're going to run their businesses a little bit different. Florida, the blood supplier in Florida, has opted that they are happy to sell the blood to EMS, but they don't want any returns. So unfortunately, if that blood is not used, it gets discarded, which is expensive and frustrating to those agencies. And they are working diligently to try to find a hospital partner to take that blood.
And part of this is like, since I've always touted what the work you're doing down in San Antonio is the gold standard. So like, that being said, for those agencies that are trying to figure this out, reach out to Randy first and foremost. She can get you connected. But like San Antonio, the model there, if you want to talk about as little waste and best like use of a very valuable resource, San Antonio has always been the gold standard. King County, I believe the blood is coming back to Blood Works Northwest as well. One quick plug. So you heard Randy mention low titer O negative. So what that means?
Positive. Positive.
Sorry. Thank you.
You're
good.
You're good.
O negative. We'll take all O negative. But bottom line is this: if you're a type O blood donor or have type O blood, one of the best things you can do for your country, if you want to pay it forward, is go donate blood. Because
absolutely,
there is a massive blood shortage, and if we're going to continue to expand this initiative across the country, we need type O blood. And low titer O basically means there's less proteins in your blood that's going to cause a reaction to someone who might have a reaction. That's the super layman's term. Hematologists, don't get angry at me now too, please. I'm just trying not to make everybody mad, but this type O blood, go out and donate it, because that's what we need in the field. And to be fair, guess what? If you get in a bad wreck and you're in a system that has whole blood in the field, it could be your very own blood going right back into you.
It can be. And we will take all blood donors because, you know what? We've talked about low titer O positive whole blood. The fact is, there are a lot of these blood suppliers that aren't manufacturing it yet. So, because again, it's a business decision whether they want to, open up this production line. So we've got agencies that are carrying O negative pack cells, but those are also in short supply when only 7% of the population is O negative, for 100% of emergency release. So plasma, liquid plasma. If you're an agency thinking about doing pre-hospital blood and you're waiting around for whole blood to be available, don't. We've got opportunities. If your blood bank or your blood supplier will give you liquid plasma, take it. It's good for at least 21 days. It's a lot cheaper than whole blood. Pack cells and or plasma. There's a lot of options out there. We want to make sure agencies aren't waiting for the gold standard. It's not that those are less, but we are tired of watching people die.
And I think the best way to describe it, and we'll go back to the layman's terms here. So like, say my car takes 0W20 weight oil. If I put 40 weight heavy diesel oil in it, it ain't gonna be best. It's not gonna blow my motor up. It's gonna get me to the finish line, but it's also gonna allow me to get into the shop where I can change my filter out, I can change my oil out, and then my motor's gonna keep running. It's not like dumping antifreeze in there, which I like to. That's saline, but like if we're getting at least something close to oil, which is plasma, and for those unfamiliar with the blood resuscitation, like, your red cells carry your oxygen, your plasma has the volume capacity and the clotting factors, which is huge. So when I flew, I would always have 2 units of whole blood, low titer O. Then I'd have pack cells, probably 5 to 6 pack cells and 5 to 6 plasma, because if I have someone with a non-compressible bleed, they're buying plasma because it gives me volume expansion and then also potential clotting. And then if I get a clot, I'm going to start dumping red cells to try to correct the oxygen and the hemoglobin deficiencies in there. There's your science lesson for the day, friends. Don't ever ask me. I blacked out for a minute. What just happened? Who am I? Who are you?
Better than I could have done. So well done. We'll take it.
Occasionally, I pretend to know what I'm talking about, but don't tell anybody. Oh crap!
Fake,
We're
fake it
we're
till
on,
you.
we're on a podcast. Speaking of, so I wrote down LE rigs, so law enforcement. Are you seeing any agencies that have like law enforcement? Besides, so we'll talk about the Texas Rangers in a second, but
Mhm.
any joint enterprise between EMS, fire, and law enforcement, where like say your patrol sergeant or your shift supervisor is the one carrying blood products for the medics on scene?
Yes, yes. So we've got Indianapolis,
Okay.
Indiana. So they have a fire EMS medic that is on their tactical EMS team, and he is responding with blood products, either going out as part of the mission or standby. Fairfax County Police
Oh,
in Virginia is carrying it. So we've got about 3 or 4 tactical teams. We would like to expand that. I think this is a great solution. And, we'll talk about the Texas Rangers in a minute, but blood needs to be considered a capability when you were
yes.
developing your mission plan.
Yes.
That's the other piece of my training is we talk about blood by the patients, by the eaches, but I want them to start thinking about it as they know exactly where their fire apparatus is. They know exactly how many
Hmm.
ventilators they have. They need to know how many blood products and where they're located so that we
Yep.
can start getting those, pushed for when bigger events happen.
I love that you brought that up. So I do some volunteer consulting work with our state patrol SWAT team out here, and that's one of the things I'm pushing hard for mission planning is like, where's your first blood supply? Even if it's fixed facility, like because that's our trauma system out here. We have a level 4, like a 4-level trauma system. That level 4 may have the ability to type cross match and start resuscitating, so you shouldn't overlook it. Or what helicopter platform has what. So like I love the fact, and if you ever need help with the mission planning aspect, please let me know. This is a passion project of mine. It's spot on. I think for all our law enforcement listeners, and even your fire listeners, like you should always have a base plan in your region of where is your closest blood. Because I did a big mass call training event for one of our South King County fire up here, and our level 3 trauma center was 5 minutes away. And I asked the question to the battalion chief on the ground or the firefighters, like, is there anything wrong with throwing 8 of these red tags in this BLS rig, having them drive the 5 minutes to that ER, and getting them into the facility? And they're like, I guess not. It's just like getting people to think outside the box. Like at the end of the day, and I'm going to credit, I don't know if you know Ahmad Hawk. He was one of the surgeons out of Madigan, the out of town guy. He was one of the most pivotal people in my career to help me understand that concept of continuum of care. Like, because you brought it up, it's not so much about can they get surgery in the field? No, it's like, all right, event happens, the whole golden hour phenomena. Like, it's not necessarily wrong, not founded in hard science, but just common sense. Like, insult happens. I only have so much compensatory neurotransmitters. I only have so much time I can bleed. So what I need to do is get to aggressive resuscitation as quick as possible.
And
That,
early.
early aggressive resuscitation, and I think that's trying to get people to understand what we're talking about is that it's sick patient need blood. We need to get that to happen. Like we're narrowing that threshold as much as possible.
We need to be doing meaningful interventions. And I think the data is starting to show that getting blood, to the scene on board is a meaningful intervention. Think about how
Yes.
many things we're doing that maybe aren't meaningful. How much time are we spending putting a patient in a C-collar or a backboard if they've got no indication, but
Right.
it's the lawyer's board, the lawyer's collar we're putting on. Teach a lot about damage control resuscitation. That is not a concept that has permeated the civilian side as much as you would think it has. They've been doing things, but I don't think they've pulled it all together that this thing is called damage control resuscitation.
Right. So we're going to play a pop quiz claim for Miss Randy Shaver here for our non-medic listeners. It's a simple one. It's a very simple one. So
Okay.
we're doing a lot of talk about blood. We're doing a lot of talk about bleeding. We're talking about putting blood back in. But for our people who may not have the deepest skill set, what is the most important part about someone who's bleeding?
Oh my God.
It's simple. Don't overthink it, Randy. Don't
I
overthink it.
know. Stopping the bleeding?
There you go. Boom. So for everybody out there, if someone is bleeding, your goal is to stop it.
And I
Because
would say even recognition of bleeding, because so many times as we teach in the training, there might not be any blood on the ground.
So we recently had an event. I can't go into details because it's like someone took a round to the pelvis. You get shot in that space. It's pretty easy to go unresponsive really quick because you have a massive pressure drop. And
Mhm.
yes, identify that. And this is one of those things that I teach my students is if someone is altered after acute trauma, assume it's bleeding because that's most likely it is. It may be a head injury secondary, but if you assume it's bleeding and you start taking actions to try to find it and correct it and resuscitate, you're still significantly better off. And to be fair, even
Mhm.
if it's significant head trauma, it's probably because of a brain bleed and you still need to go get that handled real quick.
Yeah, matter of fact, Palm Beach County Fire Rescue started a new study with John Holcomb on using plasma for isolated TBI.
Oh no.
By the way, that study happened over some margaritas as we were sitting around the table here
I
in Texas.
believe it. All the best innovation happens on a cocktail napkin and with some happy hour drinks. So
It did. So yeah, that isolated traumatic brain injury. Think we need to get early resuscitation going. Recognition. I mean, that's the key thing. Is recognizing what it is. If they're already altered, you're behind the power curve.
yes, 100%.
So making sure that you are jumping on it quickly.
Yeah, and that's kind of my big red flag thing. And for anybody who's a lay rescuer or a bystander, it's that early recognition, early activation, and then I do a lot of active shooter training, and I do public safety consulting for schools, and like it's a bit of a morbid joke, I get it, but it's like it's really easy to teach kids how to do bleeding control. Hey, your buddies, if you see red coming out of your buddy, push on it wicked hard. I appreciate the Stop the Bleed coalition and all this, but I think like we need to emphasize the simplicity. Like, and I even tell like all my first responders like with these 10 things, I can stop all true controllable massive bleeds in 10 seconds or less upon patient contact without a
Mhm.
tool. I think that's a big takeaway. So in conjunction with all like the resuscitation work, are you doing any sort of like heavy hemorrhage control training as well, or is it primarily focusing on resuscitation?
No, and that's part of the Spark Academy initiative, and we are working on a website. We just officially stood up as a nonprofit, but we've had 5 courses, and it starts with the first step, hemorrhage control, and then you can move into blood, and then you can move into TXA or calcium. But none of this is any good if you completely miss the fact that they are still potentially spurting somewhere that you haven't found yet.
Yep, that's a funny thing.
Yeah,
Ask you a question.
we see it as a bundle of care, right?
Yeah.
If
Oh, it's a
can't at
doesn't
the
have vacuum. Yeah.
yeah. Yeah.
Question for you about TXA, since it's something that
Don't ask me any scientific
I'm not going to
questions.
ask you scientific. This is all feelings-based questions. I'm a feelings for those like again for the people TXA tranexamic acid. It's been in the around forever. Used heavily in ORs for some bleeding mitigation, primarily like you look at heavy menstrual flows or specific orthopedic procedures as well. I'm not going to get into the science of it because it's exhausting and I truly don't
Yes.
understand it. But I see I'm going to ask you how you feel about this. How do
Okay.
you feel about a medic prioritizing TXA over blood products?
So I'm going to say it depends because there's been some interesting models out there. DC Fire EMS, great example. They can't get blood on their trucks on all the ambulances, right?
Mhm,
So they're doing a supervisor model. Well, traffic can be terrible in
mhm,
DC. Getting access to the patient can be really difficult for these blood medics. So they have made sure that TXA is on every ambulance so that that first medic responder can at least get the IV going and TXA on board while they're waiting for the blood. So I think in that case, yeah, you should prioritize TXA. Other systems, particularly if the patient, you get one shot at maybe, I would say anecdotally, about 50% of the blood is going in through IO because they're not able to get access. So I would say if you are going for an IO because you are not able to get access elsewise, probably the first thing you need to be hanging is the blood.
yeah. Okay. So for listeners, I try to explain to all our friends who don't understand medicine. So
Yeah,
IO,
no, Put me down if I ran, be like,
This is why I'm here. I'm here to explain the nuances. So IO, which stands for interosseous, essentially it's a an easy way to get access to someone's vasculature because your bone marrow is connected to your blood vessels. It allows us to basically drill into your bone, get access that way, and we can start resuscitation. And then the goal is to upgrade to intravenous, so actually into a vein. But yes, so IO is a preferred code. We call it a code line because it's pretty daggum easy to do, and it does get some decent flow rates. But I want to emphasize on your point is like you brought up what I was getting at. It's like if you have one line and you have blood products versus TXA, like you should blood first because that's what's going to fix them. Because I think that's one thing I've noticed in military medicine is you got a lot of people that look at TXA as like a true life-saving drug, which we can argue the semantics, but in my personal opinion, like it's an adjunct, not a true life-saving intervention. Again, that can be argued to death, but like, yeah, I think that's the big thing is when I see training scars and algorithm scars when I see people prioritizing their TXA when their blood bag is sitting unprepped next to the patient, not spiked, not warmed, and just sitting there. So we got to the roundabout agreements of what we were talking about here.
yeah, and that's the beauty is teaching these medics to think, right? You've talked about it. Yeah, in DC Fire EMS, that TXA first approach works when you understand the operational context of their environment and access to blood supply, which is different. San Antonio, I don't know if they've put TXA on every ambulance yet, but I do know their blood jump bag has the TXA in it, so that when they are starting the blood, after the blood is done, they flush the line and do the TXA.
Nice.
So it goes back to what works best in your system.
And I think that's a big one too. And you brought up the trainingisms. Like since we do talk about training, it's like how this since we have a lot of people who are in the training space who listen. Like, how do you inspire students to think critically and not just accept the face value of, say, a CPG or a guideline or a protocol or an algorithm?
So part of it, like the magic of like the Spark Academy that we're doing, is that we have different disciplines that come in and talk. So we've got a trauma surgeon, we've got, paramedics, we've actually got a few volunteer SEAL medics that are coming in to share their experiences, an intensivist, a trauma surgeon. So showing that they get excited when they hear from people that aren't just at them. And we talk about the why. Like, we're going to teach you how to set up the line, but you better understand why. Why are we doing TXA? Why are we doing calcium? The other piece to this is that we have partnered with TACMed, who has a high fidelity mannequin. So as we are talking through a scenario, when they can't get that bleeding to stop, it really is humbling when you're like, oh my God, I really do need to get my finger in there.
Which mannequin are you guys using for the TACMed mannequin?
I have absolutely no idea. The one that makes the big mess on the floor.
Oh, yeah.
See, that's how bad I am. I can find out.
I know it's probably a Trauma FX. I can't figure out who the prime Trauma FX. Yeah, so the trauma. Yeah, that's my favorite bleeding control model because that inguinal bleed.
Yes.
It's not hard to do right, but if you start packing it and trying to put a tool on top of it, it goes to a mess quick. And that's actually when it comes to simulations, if you need a HemCon simulation out there, like sure they're wicked expensive, but since I can turn the remote around and show the student like, hey, this is how much blood they lost because you're messing around with a wound pack as opposed to just like, I think that's a valuable tool because I don't know how you feel about walking into a trauma bay when there's a bunch of blood on the floor, but it tells me that there was sloppy bleeding control done.
We're sloppy and we might be messing with the things around us and forgetting to.
Yeah, because I think that's just
I think it's a nature to look at all the stuff around you. And sometimes, in my own experience, I'm probably guilty of this, of forgetting to really hone in on what I can put my finger on, or leaving the poor medic, that came in standing there holding the bleeding.
Well, to be fair, like at least someone's holding it. Like I think that's another thing too. Like for us who are a little more quote unquote experienced, at least termlessly for myself, is like also knowing when to direct people to do. So if I'm the one holding, like, and I'm the higher level of care, again, term used loosely, like maybe I can direct someone else to do that. so I can have a bigger picture. And I think that's another really hard thing to train people on is getting that recognition of the best thing. And like, I like to joke, and all my paramedic friends out there who I'm about to make fun of, it's just making fun. Why are medic shirts white? Because they're not supposed to get dirty. They're supposed to be watching and telling the firefighters in the blue shirts what to do. Because if you have a medic covered in blood, and there's a full scene of freaking a full engine company, a truck company, a BLS rig, a BC, freaking a bunch of cops, then if the medic is covered in blood, they did something wrong, because bleeding control is a BLS skill. I will emphasize that all day, every day, and this is why I joke with my medic friends. That's why your shirts are white, because you're supposed to be the attending, looking grumpy in the corner.
I had not heard that before.
It's a pretty special one. Not a special one, I should say, but it's just my. I like to. I got to needle my friends. That's why I wear black, because I'm a bad medic and I get my hands dirty.
There you go. We have to be able to laugh at ourselves, and I think
Oh.
we've lost that.
God.
I'm a nurse that's worked a little bit outside the traditional roles, and I have to make fun of myself even when I'm teaching blood. It's like, hey, you run into the nurse ratchet who takes your paperwork and throw it away. I might have been that nurse ratchet. By the way, that's a big generational gap now.
Like, what are you talking about? Like, okay, go back and watch this. Look it up. Yeah, no, it's great. Like, I air my dirty laundry. Like, I tell this story routinely, but one of my first patients I ever had was having a panic attack, and since the only thing I knew how to treat was anaphylaxis, I convinced him he was having an anaphylactic reaction so I could give him an EpiPen.
Needless, with the data presented in front of you.
His shortness of breath was because he was having a panic attack, not because he got bit by something. So,
just in case he had an underlying anaphylaxis.
Yeah, just in case, my PA made fun of me for that one, but hey, it's good. I think the big thing too, like especially in the training space, like for all the people listening who are in the training space, like no one likes that instructor with a chip on their shoulder, like who just thinks they know it all. It's like, no, I'll tell you right now, like all my law enforcement partners out there, all my buddies from working at WRCTC, like some of the best ideas, some of the most outside the box thinking came from patrol officers because they weren't conditioned to think of tool-based medicine like we are. And I think that's the big thing is about both of us. I feel like we're lifelong learners and can always learn from someone. Well, I think we've rambled a little bit. You got any final things you want to throw on the wall to stick out there? We've
got a lot accomplished, but we still have a lot to do. Less than 1% of ground EMS agencies are carrying blood. So about 220 when we last ran the data. So we've got a long ways to go. I am passionate about getting it on the civilian side because when the next war happens, the first thing we're going to do is look to the civilian side and see what they're doing. Part of my passion is in that Walker dip is if we can get the civilians doing it better and more efficient than we did, we will get a return on that investment when we end up having to use blood in, scenarios, whether it's large scale combat operations or these continual regional things that pop up. We've got soldiers dying every day and civilians dying every day. So the old farts like us, you were too kind with Legend because I can't get my boys to brush their teeth. So I feel like if I was any kind of leader, I'd be able to get my boys to brush their teeth.
Being a parent is the most humbling leadership experience you could possibly, or leadership challenge you can have, I should say.
I have two 16-year-olds right now that I have twins. So they are always letting me know how, let me say, I must cringe.
Yeah, the cringe. Randy, I want to say thank you for coming on. So I will try to throw it up in the description of the podcast. But if you need any information about blood products, trying to get it into your agency or space or training, you can reach out to Randy at schaeferconsulting.net or look her up on LinkedIn. We'll try to get in the description as well. But Randy, thanks again for coming on. Really appreciate the chance to chat with you and let me know if there's anything we can do to help. Absolutely. I'm sure we could continue talking. So reach out if you have questions. I'm here to help.